Good morning. My name is Michelle McAllister, and it is May 22nd. This is going to be a discussion of two different cases that we're going to look at today. These cases are for Unit 4, and they will be our last case discussion. The first case is regarding a patient that is diagnosed with gout, and we're going to look at the mechanism behind the diagnosis. The second patient is a woman who is complaining of fatigue and other symptoms that are associated with a vitamin deficiency, and we will look at our options and determine which vitamin she may be lacking. So with our first patient, we have a patient who has come in and has all the classic signs of being diagnosed with gout. We have the pain in the toe, somebody who is obviously at some point has increased their sugar intake, as we'll mention later. What we're trying to do is look at the pathway for which this diagnosis was acquired. So we have a couple of different options. The first option is going to be a decreased urinary excretion of uric acid. And then our second option would be an overproduction of purine catabolites, overexcretion of purine catabolites, as well as an issue with the salvage of purines, so decreased salvage of purines. So each of these will have lab results that are going to be consistent with their diagnosis. And from what we are looking at, the best explanation for this patient, I would say, is due to decreased urinary excretion of uric acid. We've learned in this class that most cases of gout reflect abnormalities in the renal handling of uric acid, as opposed to an overexcretion of purine catabolites. Our patient also presents with some lab results here where it looks like our blood uric acid is raised while our urinary uric acid is not. With an overproduction of purine catabolites, increased urinary acid during urinalysis would be expected, as well as increased plasma urate. We don't see that here with our patient. Similar lab results would be expected for the decreased salvage of purines, which would rule out these two explanations as the mechanism behind the gout. Consistent with our findings, our patient has not reported any neurological symptoms, especially including self-mutilation, which is going to be indicative of a Lesch-Nyhan syndrome. This is a deficiency of the hypoxanthine guanine phosphoribosyltransferase transferase, a deficiency in the transferase, which is a salvage enzyme. There are some more tests we could opt to run on our patient. When serum urate levels exceed the solubility limit, sodium urate crystallizes in soft tissues and joints. This causes inflammation that is so characteristic of gout and can be the most painful part. So what we could do with this patient to confirm our diagnosis of gout by way of decreased uric acid excretion, we could test the synovial joint fluid to see if there are crystals present, these urate crystals that would form in the joints. This could also be done with ultrasound testing or DECT scanning, which is also known as dual energy computerized tomography. The last part of our patient who has been diagnosed with gout was that he had a request about whether or not drinking the soda was healthy. He'd mentioned that at some point he had switched from diet sodas to full sugar sodas because he had heard that diet sodas were bad for him. This is not something that we will want our patient diagnosed with gout to do. The patient states he'd been drinking 4 to 5 liters of full sugar soda a day. This would not be ideal, as the increased intake of fructose, or that high fructose corn syrup that we often see in full sugar sodas, is going to increase the risk of gout due to an increase in purine metabolism, which will lead to increased uric acid production. So with somebody who has compromised urinary excretion of uric acid, this would be a very dangerous thing to do and would not be recommended for our patient. Our second patient has presented with weakness, a loss of balance, tachycardia, and a red beefy tongue with the loss of papillae. So this is something that immediately we're going to look at vitamin deficiencies. So we do have some options as far as what her deficiencies might be. We are going to look at vitamin B12, vitamin B6, and iron. It is noted that our patient has a clinical diagnosis of megaloblastic anemia. So that's something that right off the bat, from working in healthcare, that you know that is usually going to be tied to some sort of vitamin deficiency, most likely vitamin B12. But we'll continue to go ahead and research and see what we can come up with. Clinical diagnosis of megaloblastic anemia would indicate a folate deficiency. Folate deficiency could be a result of this pernicious anemia, which is an illness that occurs when vitamin B12 deficiency impairs the metabolism of folic acid. Megaloblastic anemia describes the disruption of erythropoiesis, causing immature precursors of erythrocytes to be released into circulation. There's irreversible degeneration of the spinal cord in pernicious anemia as a result of this failure of methylation of one arginine residue in myelin basic protein. So what that all means is that this could be the cause of our patient's numbness, tingling, and decreased sensation in her lower extremities. So that's very important because you would see similar symptoms of fatigue possibly with iron deficiency, but the lower extremity sensations would be definitely indicative of a B12 deficiency. The most convincing symptom is the symptom that she describes as the beefy red tongue. There are a wide range of oral signs and symptoms that may appear in anemic patients. This is a result of basic changes in the metabolism of oral epithelial cells. These changes give rise to abnormalities in cell structure and the keratinization pattern of the oral epithelium, which leads to a beefy or inflamed tongue. This is again something that would be characteristic of the B12 deficiency as opposed to a B6 or iron deficiency. One thing I did learn from this course is that vitamin B6 deficiencies are extraordinarily rare. So even though our patient, of course, could be suffering from this deficiency, again, that is not the most likely cause of our patient's symptoms. She also presents with a variety of symptoms that are classic for B12 deficiency, which makes this the best diagnosis. Again, though iron deficiencies can cause tiredness and shortness of breath, it's more likely that our patient suffers from the B12 deficiency. From this diagnosis of our deficiency, we could do some laboratory testing. The most effective laboratory test we could run would be looking for MMA levels. So what this would be with that methylmalonic acid. We could check the levels of the methylmalonic acid. That is a mouthful, say that 3 times fast, and see if those levels are high. MMA levels are often elevated when B12 levels are low. That methylmalonyl-CoA accumulates and is excreted as MMA during a B12 deficiency. A complete blood count should also be done just to go ahead and assess the size and number of red blood cells that our patient's presenting with. The last part of our case of our patient diagnosed with her B12 deficiency, we are looking at B12 and what it does, how it affects purine and pyrimidine synthesis. So this is going to be a mouthful, but folate and B12, vitamin B12, which work very close together, are both required for DNA synthesis and for maintenance of neurons and red blood cells. Vitamin B12 is important for DNA synthesis, regenerating methanion for protein synthesis and methylation. This also prevents homocysteine accumulation. So vitamin B12 and other methyl donors, such as pyridoxal 5-phosphates, PLP, and folate, are necessary as coenzymes of methyltransferase and lead to the remethylation of homocysteine to methionine. B12 is also responsible for the conversion of methyl THF to tetrahydrofolate. Both B12 and methyl THF are required for the methylation of homocysteine to methionine, which is critical for the methylation of various biological molecules, including DNA. So what this all means is that low dietary consumption of B12 results in respectively low serum levels, which induce alterations in DNA synthesis. This all ties up to mean that a deficiency of B12 may lead to DNA damage. Extensive research has been done on the ties between folate and B12 deficiencies, and there have been a variety of illnesses that have seemed to have been caused or worsened by deficiencies in this vitamin. So low B12 serum levels were found to have a critical role in neurological diseases such as Alzheimer's, dementia, autism, cardiovascular disease, and colorectal and breast cancer. So this is definitely a vitamin that you want to make sure you are not lacking. An important thing to note about this deficiency, the B vitamin deficiency, is that they are often misdiagnosed as a variety of deficiencies. This deficiency presents in so many ways that it is often overlooked. So that's why it's important to always get labs done, always get lab results, and just make sure that all of your vitamins are on the correct levels that they should be, because these could be very, very dangerous illnesses. All right, well, that is it for our Unit 4. Thank you for sticking with me, and have a good day.